Large national registries are critical in order to understand the current clinical practice in the United States. And the ACC's National Cardiovascular Disease Registry is probably the most comprehensive outcomes-based quality improvement program that we have in the United States. And someone who should be very familiar to all of us, Duke University's Dr. Pamela Douglas, a past president of the ACC. Thank you very much. You have a paper coming out in JACC. It's the December 4th issue, and you're looking at diabetics in particular and stenting post-PCI. Can you give us a little detail first as to why you did this particular study for NCDR?
Well, the value in NCDR is the penetration into virtually every hospital in the country and the size of the data set and the intensity of questions that we know very, very detailed clinical descriptions of these patients. The downside of the NCDR is that it's an event registry as constructed. So we know what happens in the cath lab and maybe in the hospital around that cath lab admission, but we don't know what happens after the patient goes home. And so we tried to fix that problem by taking the NCDR registry, clinically rich, highly penetrated, and linking it to the CMS Medicare data files about what happens to patients. In other words, every time a patient gets a medical service, there's a bill posted that goes in the CMS registry, into CMS administrative claims file. So we took the NCDR registry and linked it together, and we got the clinically rich information and the procedural information. Now we have the follow-up information.
So in this particular paper from the December 4th issue of JACC, what's it about?
Well, it's about diabetics. And we think, well, gosh, we know a lot about diabetics. We know that they are a big part of our population. We know that their outcomes are probably not as good as non-diabetics. But what do we know from randomized controlled trials and stenting and which type of stent? Well, in fact, in spite of the fact that diabetics make up at least a third of our patient population in interventional cardiology, less than 2,500 of them have been enrolled in randomized clinical trials.
Good grief.
So we're left, this incredibly important patient population, but we're left with very little guidance. So we turned to NCDR because, again, it has that incredible penetrance, and we found 400,000 patients linked to CMS, of whom a third are diabetic, and we know whether they're insulin treated or non-insulin requiring diabetics, and we can look at their outcomes.
What did you learn?
Well, we found, first of all, that they constitute the size of the population, which is important to know, that they have a lot of risk factors over and above non-diabetics. But we learned that their outcomes from stenting are substantially worse. Which is, clinically expertise, clinical experience would dictate that, but they're twice as bad. For death, they're twice as bad. For MI, they're worse for revascularization. There's 40% more bleeding, and it's incrementally worse depending upon the treatment.
Is it time to rethink our use of PCI in this population, or just the number of people or how we choose patients?
I think it's time to rethink our patient populations for the randomized controlled trials. So, NCDR can't say is there benefit to doing an interventionist patient versus not. That's a completely different question, and the outcome may be 3 or 4 times as bad, without the intervention. The intervention, there have been good trials in diabetics of surgery versus PCI in Barry and East and those trials. But we haven't done trials of type of stent or type of therapy in diabetic patients in spite of the size of the population.
And if I remember right in your paper, you did not find that the type of stent, or there were just, in some analysis, there just wasn't very much difference. All diabetics didn't do particularly well.
Well, all diabetics didn't do particularly well. The difference, the improvement in outcome that we see in registries with drug-eluting stents over bare metal stents is replicated in the diabetics. So I think that can be very reassuring for many people that we're making the right decisions. Now, there's obviously selection bias in a registry that doesn't exist in a clinical trial, so that's more hypothesis generating rather than, the final answer. The other thing that I thought was interesting in hypothesis generating is that excess bleeding in diabetics. So it's not just about the stent, but the risk-benefit ratio of dual antiplatelet therapy after a drug-eluting stent may be different in a diabetic. Or at least here's a signal to suggest that it may be. we need to do that study and really figure out if we're placing our diabetic patients at excess risk.
We need to get more than 2,500 patients enrolled in trials.
Absolutely.
So other than that, any other clinical take-home message that you'd like to mention?
Well, I think that's a lot to learn from one study.
Yeah, it really is. Just essentially be more aware of your diabetic patients.
Right. Be more aware of their bleeding risk. Know that their outcomes are going to be worse, so they need more aggressive medical therapy. And let's find out more about this patient population. It's too important to be so understudied.
The paper is in the December 4th issue of JACC, and the NCDR, of course, is online. It's online now, too, before publishing, so please go to JACC Online and see this paper by Douglas et al. From our friends at Duke University. I'm Rick McGuire, the executive editor of CardioSource Interventional News.